arachnoid matter. Then you have the subarachnoid space between the pia mater and the arachnoid mater. And then you have the brain substance itself. It's called branchimatus or intracerebral hemorrhage. Okay? Epidural hemorrhage بيحصل between the dura mater and the bone, and it is almost always of traumatic etiology. دائما. يعني it does not happen spontaneously. You know, it happens to people who are involved in a sort of trauma, car accident, whatsoever, right? And you get accumulation of hematoma between the bone and the dura mater, and they present clinically as specific. Okay, and the presentation could be insidious and slow, or it can be abrupt, based on the size of the hematoma itself. Okay, and you know, you have this is a general principle. Space occupying lesion, you know, in the beginning they will have non-localizing symptoms. قلنا لكم دي شنو اكيد عمار قال لكم وغيره قال لكم. And you get headache, vomiting, confusion, they become delirious and so on. But once you start to have a localizing signs in terms of a motor deficit or a sensory deficit, okay, then that means your disease is getting established and progressing. Okay? Right, next. Next, we'll talk about the subdural hematoma. The subdural hematoma is collection of blood between the dura mater and the arachnoid mater. And, you know, again, the subdural hematoma is almost always traumatic in nature. It doesn't happen spontaneously. Okay? And to know the mechanism of subdural hematoma, you have to understand something little but very important. That the venous return from the brain surface, the veins cross this space, subarachnoid space, to go to veins in the dura and the sinus in the dura. You know the cervical sinus and all that, the sinus in the dura. This is where you get your venous return. And these small venules and veins that goes from the dura to the dura mater, they go vertically. Okay? So any juggling movement that if you move suddenly forward and backwards like this, that checks your brain insides, is likely to cause severance of these veins and subdural hematoma. So, and this type of injury is really very common during car accidents. You know, you are riding a car, brake, okay? And, or if you have a hard strike to your heart, hard enough that your brain moves inside, from side to side or from backward. And of course, the older you are, the more liable you are to develop subdural hematoma. Even a minor trauma to your head can produce subdural hematoma. Okay? And usually, subdural hematomas are insidious and limited in the beginning. But then they grow with time. They grow in, not because there is a continuous bleeding, no, not necessary to have a continuous bleeding for the subdural hematoma to grow larger. You know, the hematoma itself will be osmotically active, and it will uptake water from the surrounding and become cystic, and it grows. Okay? So people with subdural hematoma, they say, Allah يا دكتور أمس ضربت راسي بالحيطة، ضرب كبير عادي، ضربت راسي بالحيطة ما بعرف شنو، يعني شوية صداع لكن حسيت جيت شوية كده لغاية ما تجيه فوكال deficits in terms of media or okay. Next. You know that these hematomas are very easy to diagnose, not like before. You know, before, in our time, when we suspect a subdural hematoma, right? Because the X-ray is not is not clear enough to diagnose these things. Now with CT scan, you can see the hematoma. It's there, concave, collection, pushing the brain to a side. That we never used to do. So what we do? What do you think we do? نفتح فتحة في we make a bar hole to see if it's or no. If the silent is sitting on the left side, we make a bar hole on the right side. Okay? Really, that was the practice before. You are lucky. You are living in a better. Okay? So the treatment is evacuation. Some of them, if they are small, they can resolve their self-harm. If they persist, getting large, become cystic, then you will have progressive symptoms and signs until it is evacuated. And the outcome is good, really, management. Next. A subarachnoid hemorrhage, this is a different story. First of all, the main difference between epidural, subdural, and subarachnoid hemorrhage is that the first two are localized because you have tough tissue around them. But subarachnoid hemorrhage, the hemorrhage is occurring in a space which already exists. You have already a space where the CSF circulates. Okay? So this is how it will look when you remove a brain of somebody suffering from subarachnoid hemorrhage. It will be diffused around the whole brain. The whole brain will be hemorrhagic and red. And subarachnoid hemorrhage, the main cause of subarachnoid hemorrhage, cause number one, ruptured perianeurysm. And the way, it is this ruptured perianeurysm, it happens suddenly. But yeah, you don't need to have a trauma. Usually, you have the perianeurysm, congenital aneurysm, it is there. And the wall gets weaker. When you are an adult, you are weaker. If you get hypertension, if you get anything that led to increased pressure in your circulation, it will rupture. And usually it is sudden. Some people, they are lucky, they get warning signs. And I'll tell you now, if anybody complains of severe headache, okay, severe headache in young age, around the age of 40, you better think of it. Because sometimes, you get small leaks. You don't get a full rupture. Small opening, small leaks, got sealed, then again it opened, got sealed, and the patients get severe headache. The headache of subarachnoid hemorrhage is terribly severe, and it is the main presenting sign. People will come with sudden onset of severe headache. What is the problem of why people die? The mortality is very high. First of all, most of the time it is missed. واحد يجيك كويس نصيحه يقول لك انا عندي هذاك الاسبرين بتاعه والقصه مدوره جوا البليدنج شغال كويس. Once, first of all, it is very irritating, the meninges. You will have all the symptoms and signs you see in meningitis. You have the irritation, neck pain, headache, blah, blah, blah. And then, as the hematoma grow, what it will do? It will produce some pressure. What the pressure will do? It will occlude vessels. And not one or two, it will occlude the whole circulation. So the secondary vasoconstriction, vasospasm, will lead to infarction. So it will be complicated by infarction. Sometimes it might rupture into the ventricular system. Okay?
We should be cautious لو كان عندنا severe headaches we are young لو الواحد جاءه صداع شديد.
أيوة be careful. أنا عندي one of my colleagues, he's still alive. He got treated. But his, the error of angiography. They put a clip very easy. Next. And then we come to the major hemorrhage, which is the intracerebral hemorrhage. And intracerebral hemorrhage is when it happens suddenly, okay, and it is immediate symptomatic. And the word stroke, when they talk about stroke, they talk about either intracerebral hemorrhage or cerebral infarction. Okay, and it is not traumatic, very rarely traumatic. Usually, it is because of a pathology inside your brain, something like amyloid angiopathy. I told you about that, no? Mm. And aneurysm, vascular malformation. Aneurysm, I don't talk here about perianeurysm, genital aneurysm. No, I'm talking about an acquired aneurysm. Okay, aneurysm you develop during your life. And the commonest type of aneurysm you develop cerebrally is a mycotic sort of aneurysm. When the patient has an infected endocarditis and they shoot septic emboli, they get lodged into the cerebral arteries, they weaken the artery, they develop aneurysm. That type of patients, they can get severe cerebral hemorrhage. So usually it occurs in these conditions, and high pressure, high blood pressure is precipitating factor. Okay, if you have already an aneurysm or you have already amyloid angiopathy or you have malformation, when you get high blood pressure, then you are likely to develop. Okay, sometimes cerebral hemorrhage complicates malignancy. You have a brain tumor which undergoes necrosis, and the necrotic process involves one of that. بس انا زمان كلمتكم قلت لكم الانفاركشن in the brain either is red or red. The red one is associated with damage, okay? And as I said, it's the same. Severe, non-localizing, and then localizing, and if things continues with herniation, not herniation, then sudden death. Some people, they recover. Yes, they recover with residual weakness and so on, but some people are recovering. This stroke, you either recover or you are dead. Next. Then we'll talk about the infections. Infections are very common. But somebody might say, what has this to do with spacing tubercular lesion? Yes, some of the infection produce spacing tubercular lesion. Okay? And others, they just produce edema, which leads to increase in peritoneal pressure, and I'll give you all the signs and symptoms of increase in peritoneal. If it is complicated, the edema of the brain, if it's complicated by infarction, then you get another additional thing, which is localized. Okay? And this human brain, in spite of the presence of the brain barrier, but it is subjected to all types of infections. Some of them are very funny. All types of it could be virus, it could be fungal, it could be parasitic. Okay? And how do these microorganisms reach the brain? Yes, they can reach the brain hematogenously. قلت لكم جبالك اديتكم مثال endocarditis, infected endocarditis, can shoot an embolus, which is infected. Okay? Or the organism can break through acute phase into the vessels and you get septicemia. Okay? And then you can get direct implantation, and that happens only in trauma. Okay? And there is a major cause of this infection is transplacental transmission, especially for cytomegalovirus and toxoplasmosis. These two infections can be spread from the mother to the child transplacentally, and that's why they present early in life. Okay, and then you can have a local extension from the head and neck region, sinusitis, okay, otitis media, pharyngitis, mastoiditis, all infections in this part of your lower part of your skull. If you get any infection there, it can go up a reach the brain. Okay, and it can be transported through the nerves. And the best example is rabies and herpes. I think it's not a rabies. Okay. So these are the methods. Huh? Huh? ماشي أنا الله يمر عضاني كلمة سمعان صعب طيب what we go forward والله الشارع كعوة. So we will start talking about infectious diseases of the brain, and you know the brain has got two parts: the meningeal covering. If you get infection of the meningeal covering, you get what's called meningitis. And you have the brain substance. If you get inflammation of the brain, then you have encephalitis. And most of the cases, you have meningoencephalitis. Or one of them will go to the other. Either the inflammation or the infection of the brain substance will reach the meninges and you get meningoencephalitis, or from the meninges it will go to the brain and it's called again meningoencephalitis. Okay? And the commonest among all of them is acute meningitis, especially in dry, hot areas like in the tropics, where you have the meningococcal epidemics that comes during the dry season. Okay. Besides this, you have other bacteria from your body, from size of inflammation, like pneumonia. You can get pneumococcal meningitis. You get all types of bacteria. Okay. So you have the endemic one and the sporadic meningitis. And it can be also caused by viral infection, and this is called aseptic. The bacterial gives a biogenic sort of meningitis. And then you have the chronic meningitis, which is caused by organisms that tend to resist the immune system and stay for longer time, like tuberculosis, spiked syphilis, and something like that. So the acute meningitis has two main causes. Number one, bacteria, and bacteria gives rise to a purulent sort of meningitis. And then you have the viruses which give aseptic meningitis, and you have the chronic form of meningitis in terms of syphilis, tuberculosis, or fungal infection. Okay, next. So what happens if you get virulent type of meningitis? And what causes virulent type of meningitis? Virulent type of meningitis in children can be caused by E. coli, by streptococci. In adults, Neisseria, and you have pneumonia, which is very important. Okay. Once they reach the meninges, these bacteria, they initiate an acute inflammation of purulent type. You know that acute inflammation are of different types, isn't it? You have serous, you have purulent, you have fibrinous, correct? You know all these types? So these types of inflammation you get in the meningeal space and the meninges is purulent type of inflammation. You have exudation of neutrophils or of fluid-rich neutrophils. Some of them are dead. That's why you get this yellowish sticky thing. Okay? And meningitis, it is the main symptoms and signs of meningitis are related to meningeal irritation. You get headache, severe headache, you get neck stiffness, you get fever, you are not fully conscious, okay, get photophobia, and you can become easily irritable. Things that does not make you angry makes you very angry when you have meningitis. So these are the main symptoms and signs that comes from meningeal irritation. This is the same things you get in subarachnoid hemorrhage too. Okay, headache, stiff neck pain, cloudy consciousness, photophobia, become very irritated, and so on. And of course, the first thing you do when you suspect meningitis, acute meningitis, you do lumbar puncture. The examination of cerebrospinal fluid is diagnostic. In virulent meningitis or in bacterial meningitis, you will have three features which enable you to diagnose it. Number one, you will have bus cells or neutrophils. Number two, you will have low sugar. And number three, you will have high protein. Sugar and protein and inflammatory cells minimally present in normal cells. And once you get acute biogenic meningitis, you get a lot of these neutrophils. The sugar level will come down because it's consumed by the bacteria, and the proteins will climb and increases. Meningitis is a killing disease, a fatal disease, if not a lot of complications. لكن واحدة من الكومبليكيشنز المهمة جدا 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 you get meningeal encephalitis secondary to meningitis, and that is because the infection will be spilled directly to the brain substances, and it is not only the infection of the brain stuff which is dangerous. What is dangerous is the vasculitis and the thrombosis and the hemorrhages and the infarction you get following that. Yeah. You get meningitis, lucky, diagnosed, treated well and good. No, get complicated. Bacteria will move into the brain substance, it will invade the vessels. It's called vasculitis, thrombosis, infarctions, and hemorrhages. Okay, that's why meningitis is a fatal disease. And then, if you are lucky to survive for a few days, you might get brain abscess. Okay, if it is not appropriately treated or inadequately treated. Okay, يعني مثلا تمشي في حته يدوك اي انتي بايوتيك زي مصيبه الزمان، لكن طبعا يقول بلاسي زي يدوك كلشر مش كده السياسه ياكل بكتيريا شنو سنسيتيف شنو يدوك ضباط لكن تمشي حتات ما يعملوا السياسه يدوك اي انتي بايوتيك that does not kill the bacteria completely. Okay, it is او يدوك suboptimal dose of antibiotics. بالمناسبة suboptimal dose of drugs are very serious. Okay, if you get suboptimal doses of the treatment and it becomes prolonged and resilient and so on, so what is next? Healing. The body will try to heal itself. Healing by what? التالي دي كلها healing by fibrosis. بس البرين والمنجز ديل لما تحصل فيهم irreversible synovial cell necrosis, they heal only by fibrosis or gliosis, or in the meningeal space fibrosis, in the brain gliosis. Healing by fibrosis and gliosis will create a lot of problems. First of all, you get hydrocephalus. Now, when you get healing by fibrosis in the meningeal space, you get obstruction of the normal CSF flow. You get backflow and obstruction. Following the obstruction, and then you get hydrocephalus. Okay, and if you have gliosis, you can get something like seizures. You have something like neurological deficiency, weakness, sensory abnormalities. Okay, so it is not an easy disease. Very bad. It has to be diagnosed and treated. Next, aseptic meningitis. This is also again a type of acute meningitis, which is caused by either viruses or autoimmune disease. Sometimes can be associated with autoimmune diseases. The common type of viruses are rickettsial viruses. That's called the Q fever. That's the Q fever. This virus is a common cause of meningitis, and again, it is the same problem, the same symptoms and signs. لكن bacteria virus. It's okay. Any virus can cause. في حاجات كثيرة غيروا الكلاسيفيكيشن بتاع الكلاميديا كانت شنو بقت شنو؟
بكتيريا.
وكان زمان شنو؟ طبعا I'm not following the developments in my world. It's good you're now told me about it. I'll read more about it. Okay. The viruses, they unlike bacteria, they've meningitis is characterized by lymphocytic infiltration, not neutrophilic infiltration. So when you do the CSF, you don't see high neutrophils, you see high lymphocytes. Okay, and the sugar will be mildly reduced, while protein will be high. Okay, and the diagnosis is not like biogenic bacteria. You do culture or you do gram stain, and I forgot to do gram stain. Because you know, in CSF, when you suspect meningitis and you do CSF and it is high neutrophils, you do gram stain to see the type of bacteria present. And you do cultures. Here, gram stains and cultures are not helpful. The best thing to diagnose viral meningitis is PCR. Polymerase chain reaction. Exactly the type of a virus that is involved. Okay? Next. Chronic meningitis, زي ما قلت لكم, it is a chronic disease. It's characterized by the presence of granulomas. It can be caused by syphilis or tuberculosis or fungi, and you can see the list, very, very long list of fungi you can have. For example, histoplasma, is it fungus now or something different? Histoplasma at my time, it is a fungus. Cryptococcus neoformans and coccidiosis, these are unities, these are fungi, and these are the main causes. And people with HIV or immunodeficiency in general at higher risk of developing chronic meningitis. ما بتشوفوه نازل عادة يعني. Chronic meningitis is associated with immunodeficiency, especially in HIV. And you get all the features of chronic inflammation with fibrosis. And as I said before, and I'm saying hundreds of times, once you have, acute inflammation, it can resolve, and the body comes back to normal. Everything comes back to normal. In chronic inflammation, if it is persistent and progressive or prolonged, you have continuous cell damage, and you have healing by fibrosis. They go hand by hand. Any chronic inflammatory disease, by the way, is associated with fibrosis. So if you get chronic meningitis, definitely you'll have fibrosis, and you'll have the hydrocephalus and all these things. Okay? And in CSF, it looks like a viral meningitis because you'll have lymphocytes and you have high proteins and mildly low sugars. Okay? And the diagnosis is by doing special stain or by PCR. يعني إذا أنت in a good place, you go straight forward to PCR. If it is not a biogenic meningitis, if it is a sort of chronic meningitis or viral acyclic meningitis, you go straight forward to PCR for everything. Okay, and diagnose. But if you are in a place where you want to save money, you can do stains like silver stain. You can do something called the Nelson stain. Okay, and you can do Bass stain to diagnose these organisms. And if you fail, you can resort to PCR. Okay, next. One of the main features of tuberculous meningitis is the granuloma, the chiaziating granuloma. شفناها في الصورة اللي قبلها. كويس؟ The main feature in syphilis is an arthritis of the nerve, when the arteries sealed at their end. Okay? And this is a historical feature that help us to diagnose syphilis, tertiary syphilis. You see, this artery is becoming thickened. And as time goes, okay, the artery will be sealed. Okay? So that there will be no continuous flow of the circulation. When the artery is sealed, بيحصل شنو؟ بيحصل backflow. لما يحصل backflow بيحصل شنو؟ ischemia. طيب. This by a special stain using a silver stain. And where you see these sparachutes, this thread-like blackish things, these are sparachutes which take silver stain. And the silver stain, you know, there is one called Baltin style. It's a very famous, but there are many stains. But all of them are basically silver stains. Okay, next. Mycobacterium, you know, beside the granulomas and so on. This is if you do biopsy, but if you do CSF, you do Xenos. You will see this beaded, prolonged curve bacilli. Okay? And in histoplasma, you will see the protozoa. And here, a single cell organism. Okay? They are very goodly, very nicely, very clearly seen in Giemsa stains. So in chronic meningitis, besides the clinical and signs and symptoms, the CSF examination is very similar to the viral one. So you have to resort to special stains and sometimes PCR to distinguish between them. Okay, next. And the other thing that it is associated with HIV or immunodeficiency in general. Cryptococcus neoformans is again an organism that's commonly encountered in the meninges, especially in HIV patients. Okay, and it is encapsulated fungus which has a rarified capsule. The capsule in the Nelson is rarefied. In this brocket, it's called GMS. You know, it appears GMS. Brocket something. But the last S stands for silver. I think Brocket Mason silver something like that. Okay, but this BS you see the Cryptococcus neoformans. Next, Brenner's. Brenner lesion. Yeah. Yes. And brain abscess is caused by bacteria. But you know, it can be caused by what else? Other bacteria.
Fungi?
No. Huh? Amoeba. Yes. Amoebiasis can cause brain abscess. Very rare, but can happen. The main cause of brain abscess is biogenic bacteria. And you know, it can be either implanted straightforward or secondary to meningitis, or a bacteria that moves from the sinuses, mastoid bone, and otitis media hematogeneously and go to the brain. Another cause is bronchiectasis and infective encephalitis. All these can be complicated by a brain abscess, even osteomyelitis. يعني أي focus in the body of infection can predispose to brain abscess. عشان كده, if you have a kid with otitis media, don't be very serious about it. Okay, and it has all the symptoms and signs of specific lesion. It can rupture into the meningeal space, causing meningitis. It can spread down to the spinal cord. It can be complicated by thrombosis, infarction, and hemorrhage. And ultimately, if it persists and not treated or evacuated, you will reach a stage in increasing intracranial pressure that herniation. Next. There is something called subdural embyema. تعرفوا الإمبايما؟ When you hear embyema, the first thing that goes in bus where? Yeah, exactly. Pleural space. When you have a combination of bus in the pleural space, they call it embyema. Okay, and that's what, but you get subdural embyema very rare in the brain, and usually it is in the basal part of the brain. Okay, and it is again, it complicates foci of biogenic infection somewhere else, especially in kidney. Especially otitis media is a very dangerous disease, by the way. Okay. Next, and it can spread down into the subdural space of the spinal cord, and they call it subdural spinal injury. Next, these things you just know the names. طيب. Now we'll move to the brain substance proper. وزي ما قلت لكم انا المننجات والسيفلايتس ديل بيبادلوا بعض. Okay. Encephalitis is the inflammation or infection of the brain substance proper. Okay, and it's almost invariably associated with that. Maybe it is the right thing to call it meningoencephalitis to start with. Again, like meningitis can be caused with all these type of viruses and fungal. Arboviruses, herpes, CMV, polio, rabies, HIV, polyoma virus, fungal candida, Aspergillus mucor, parasite toxoplasma, cysticercosis, and amoebiasis. Okay, all these can cause encephalitis. Okay, and encephalitis is characterized generally by edema and increased intracranial pressure. It is not like a space equivalent lesion in that sense, but the similarity between it and space equivalent lesion is edema and increased intracranial. Okay, next. تعرفوا الاربوفيروس سمعتوا به؟ Arbovirus is a common cause of encephalitis. There are two types. There is what's called Western, equine, and Nile and West Nile encephalitis. Like in Sudan, it's common, really, by the way. And they are characterized by very high mortality. Okay, and this has a geographical distribution. Around Equatoria. It's associated mainly in Africa, central part of Africa. And it is, the patients usually present with confusion, delirium, stupor, and coma. And they get fever and all that. It has very high mobility and mortality. Histologically, it is characterized by perivascular inflammation. شوف فوق slide number B. هنا vessel which is surrounded by lymphocytes. Okay, and you can have necrosis. Okay, and you can have microglia nodule. Microglia nodule are the granulomas of the brain. هناك النكروز تحت. النكروز تحت وجنبها تقول لك necrosis. So it is perivascular inflammation. You have necrosis, okay, and you have microglial nodules, okay, and in severe cases, the vasculitis is severe enough to produce a break in the vessel or with hemorrhage, or all the complications of hemorrhage. Okay, next, HSV, herpes simplex virus. Again, this is a viral infection, very common. والحقيقة دي كلها تشاف أكثر في الناس اللي عندهم immunodeficiency, whether it is acquired or congenital. Okay, what is good about herpes simplex virus is this a self-limiting disease. It's a mild disease, but the virus can go and settle in every cell inside the brain, in the astrocytes, in the oligodendrocytes, and in the ganglion cells or layers. Okay, and it affects mainly the temporal lobe. When the inflammation affects mainly the temporal lobe, people will present with mood changes. You see that? Temporal lobe inflammation, people usually, or temporal lobe involvement, be very behavioral abnormalities. And
تحصل سوينج سريعة ولا كيف؟
يعني بيكون very moody المود dramatically change. Okay, and you know it is very easy to diagnose if you take a biopsy because we will see the virus inclusion. شايف النوم؟ Virus inclusion and virus will go and sit in the nucleus. The big thing. The chromatin is pushed to لا the chromatin. This is a nucleus, okay, and this is a nucleus. This is a nucleus involved by a virus. The virus will sit inside the nucleus and push the nuclear membrane to a side, and you see this darkness because this is the chromatin substance is pushed to the side, okay, and the virus is in structure and in color. It's very, very easy to diagnose if you see. Next. This is a nucleus, not involved here. And this, the big thing, the whole big thing is the nucleus involved by a virus. The virus will sit, grow inside the nucleus, make an inclusion, put the nuclear membrane to a side, and the chromatin matter beside it. Okay. Next. CMV. It's a LI appearance. You know, you'll have inclusions like this. And unlike herpes, particles are inside the nucleus, giving this LI appearance, or like reddish dot in the cytoplasm. Okay? Again, it is subacute disease. It is somehow limited, characterized by the presence of inclusion, but it can be transferred through the placenta. Okay, so you can see it in usually in neonates or immunocompromised children. Next, poliovirus. تعرفوا البوليوفيروس؟ البوليوفيروس is هيحصل هذاك السمول بوكس فيروس. The smallpox virus is no more there. أنتوا طعمتوا the smallpox ولا لا؟ ما أظن أنكم طعمتوا. Very very easy. تقول لي واحدة شوف هنا. خليها أسرع. Forever I have it. Because at my time, smallpox was a disaster. Okay, this is enterovirus. And in children, it's common. It causes self-limiting gastroenteritis, but sometimes it can disseminate and reach the brain and the spinal cord, where it produces severe injury and it will produce neuronal death, necrosis. That's why people come with paralysis. Okay, I have seen. You know, and if the patient survives this acute attack, because you know when you get neuronal damage, this neuronal damage might involve the respiratory muscles. In the case, so many people die during the acute attack because of respiratory failure. Okay, if you survive it, then you will have a residual change, and you will get what is called post-polio syndromes, which come later in other files, and it's characterized by weakness and resting. Okay, next, rabies. Rabies, this is one of the viruses that get transmitted through the nerves. You get a bite from a saliva, the virus will come out in the wound, in the nerve, and it takes a long time to reach the brain. That's why the period between the bite and the development of symptoms is usually, people forget that they had a bite, you know, because it is a long distance for the virus to travel until they reach the brain. And I don't need to describe, you know, rabies for you. Just you become a mad dog yourself. Honestly, you become a mad dog. You know, you start with headache, malaise, fever, and then you become very irritable. Okay, and then you will get muscle contraction and a locked jaw. زي tetanus. Yes. And then you become maniacal. Mania, You become maniacal, out of control, and everything. And you know, and hydrophobia is very interesting. I don't know, very interesting and very common. People, they don't like to touch water on the street. Yeah. Okay, and it affects mainly the brain stem, and it's a killing disease. Yeah, it's a very fatal disease. Histologically, you see what is called neurophagia. You see necrosis of neurons, definitely. You see the neurophagia. Neurophagia is this red dots, yeah, engulfed by macrophages. See neurophagia. This red dot, in the past, they were neurons. They become necrotic and they are engulfed by. So this is an autopsy finding. Yeah, next. HIV. You know, HIV, like any other virus, it's called aseptic meningitis. Okay? But the problem of HIV is not the aseptic meningitis. Aseptic meningitis is a self-limiting disease. And people can easily recover. The main problem of HIV is that it lowers your immunity and you become susceptible to all types of opportunistic infection. All types of infection you mentioned above, I have never seen it in a patient with normal immune system. Really. ما شفتها. طبعا الريفس خلوه، لكن باقي الحياة والبول ده خلوهم، لكن باقي الفيروسز ما بنشوفها ما بنشوفها كومنلي، يعني نشوفها الا في واحد immune deficient. اوكي؟ لكن الفيروس ذاته، الهيرز فيروس ذاته sometimes it can produce a disease called HAND, اللي هو HIV associated neurodegenerative disorder, HAND. Okay, and it can vary from, you know, it is like other neurodegenerative disorders. The main presenting feature of this is forgetfulness, dementia. Okay, HAND. Following HIV, dementia. So some of HIV patients, they can present with dementia. And sometimes, you know, you have another problems in AIDS patients. Once you start the treatment, okay, because of any infection, a patient has HIV, for example, he has a meningitis, virogenic, or he has a fungal infection or a parasitic infection. Once you start treating this infection, you will get an immune response. بيسموه ايريس اللي هو immune reconstitution inflammatory response. بيحصل activation من inflammatory process severely. Instead you improve, you become even worse. And patients present with cognitive problems. Okay? At the historical level, you can see and you can see multinucleated DNA in HIV. Yeah. And these are autopsy findings. This you don't encounter them really now. Next, COVID-19, the new emerging disease. Almost 80% of people who come. It's very common, by the way. That's why symptoms like seizure, confusion, headache, disorientation are common. And they have sometimes they become disabled. They have mental status abnormalities. Okay, and in COVID-19, the mechanism or the pathogenesis are two. Either the virus itself goes settle there and attack your glial and neurons and kill them, or the antibody developed against the virus acts as autoantibody and start attacking the brain tissue. So partly it is a direct, partly it's an autoimmune diseases, and you know it has severe inflammation. You can have hemorrhages, you can have infarction, you can have microglial nodules, and all this stuff. Okay, And I think it contributes to many deaths in COVID patients. Next. polyomavirus. جاسي. تعرف البوليوما ده في نوعين. اسمه بيكي. واحد اسمه جاسي. جاسي. بوليوما ار2. طيب one called بيكي. تعرف بيكي يعني شنو؟ بكري. السودانيز patient. Yeah, it's called Bakri. A Sudanese patient who's into him. The virus was first isolated in Pittsburgh in the US. Transplantation. This KB polyomavirus affects patients who undergone renal transplant, and they get, of course, drugs to lower their immunity. And this, yes, is called John Cunningham virus, and this is it is its specialty to attack oligodendroglial cells with stimulation in the brain. BK, Bakrit variant, it attacks the tubular cells in the kidneys, while this attacks the oligodendroglial cells in the brain, and it causes progressive multifocal leukoencephalopathy. It is a neurodegenerative and degenerative diseases. Okay, and that is it. You know these things. You just know you are going to do nothing about them. In fact, but you have to know them. Huh? لا بتحصل شنو لما العيال يكون عنده رينال فيلير مش رينال فيلير يكون عنده رينال فيلير ويعملوا له ترانسبلانت. It is a post transplant in the kidneys. الفيروس في الكدني بوست ترانسبلانت. كويس البيشنت بياخد immune lowering drugs مش كده؟ Yes. Get exposed to lot of infection, but one of the major infection is the BK virus. It will go and attack the tubular cells, and it will produce what's called tubulitis. So if you get a biopsy, you have to tell the physician whether this is polyoma virus that causes the tubulitis or the drug, because the drugs themselves, the drugs that are given to transplant patients to control their immunity itself has the tacrolimus. It has one of the side effects is tubulitis. Okay, and tubulitis also can be a sign of rejection. So there is a place here. So BK polyomavirus we see daily almost here in Saudi Arabia. Like in Yasi had a John Cunningham, no. They don't do the brain biopsy for that. Next. Fungal encephalitis. Yeah, you can have different types of fungi. Okay. It complicates pulmonary aspergillosis. Aspergillosis is mainly pulmonary disease, yeah? But it can go to the brain. No, I've never thought of fungal space granule. No, not there. But you know, the cavity are the neutrophils and so on. But okay, it can cause bronchitis abscesses. Infection. And you know, what you see here is you see aspergillus. And then you have that drum. You see the drum on the left, the right side. It's also characteristic for aspergillus. Next, but you can have different fungi like Candida and like Mucor. See the difference between Candida. Mucor is a broad hyphae, usually very thick broad hyphae, and Candida is a thin hyphae. Candida is a pseudo-hyphated organism, while Mucor is a true hyphated. What is the difference? True pseudo. Well, the true and this is pseudo. What is the difference? You know.
Malfunction.
La malfunction. Morphologically, a true hyphated virus is because the virus get enlarged and become longer by producing new cells. The previous cells attached to the mother cells through a true stricture, while the stricture between the cells in Candida is not true. It is not due to provocation. Okay. يلا next. Toxoplasma. هذه Toxoplasma in adults comes from cats. This is the baby through the placenta, and they have this triad, of retinitis, hydrocephalus, and internal calcification. This is the way it present as a specific lesion due to calcification and hydrocephalus. Whereas if you biopsy it, you see inflammation, you see edema, okay, and you see chronic inflammation. Okay. Spreaded tachyzoids, separate organisms. Again, easier to diagnose it when it is in the incisive form. This is the incisive form, where you have a cyst filled with the organ. Okay?
Yeah.
Yeah. Next. Trypanosomiasis. You know that. تعرفوها مش كده؟ في تروبانسوما جامبيانسيس روديسيانسيس. واحدة في إيست أفريقيا، واحدة في إيست، واحدة في ويست أفريقيا، واحدة في إيست. يعني روديسيانسيس. روديسيانسيس روديسيا. تعرف روديسيا شنو؟ غير اسمها. سموها زيمبابوي. Zimbabwe is a new name. The old name is Rhodesia, the British name. Okay, and this is it is either transplacental, congenital, or through a vector. طبعا زي الاشمانياسيس وبتشبه الاشماني organism. شوف جديد جدا جدا. It causes fever, muscle pain, joint pain, all that. بس أهم حاجة you have difficulty to stay awake. زي الخدمة. أنا طوالي. دائما في ما في داعي لازم في خلاص الفات الصوت تكون صاحي انا ما اعرف اطيب ليه قاعد هنا you are very adult. Okay, and it's a very killing disease. It's fatal if it is not treated. You see the parasites in the biopsy. I have seen a brain autopsy case from a patient from Gambia with trypanosomiasis. I've seen it. You see the brain full of these parasites. Okay, the parasites is oval shape, has a nucleus and kinetoplast. Okay. Next, amoebiasis. Yes, amoeba can cause a brain abscess. Okay, and you see the trophozoite, which is a nucleate. يعني لما تشوفوه تخيل لكم أنها هيستوسايتس أو مش كده ولا ماكروفاجز، بس هي أكبر شوية. عندها نيوكليوس وعندها فومي سيتوبلازم you see inside it RBCs. This is the way you identify it. In the brain, they cause abscesses, and the abscess usually is filled with dead eosinophils. ما ظهر يمكن لو جربت تشوفي يمكن في ديك جو لا up right up left دي فوق لك دي طوال هذه النيوكليوس RBCs. Okay. Next, cysticercosis. تينا سوليوم عندها كاركترستيك CT finding يسموها شنو؟ السيست والهوجلت they get calcified وبتديك الابيرنس دي. It is called grains of rice appearance. مش زي حبات الرز. تينا سوليوم yes. They can go to the brain and they can infect the brain. Next. Cysticercosis and the history of it. While the first one we saw the calcified cyst. Okay, it has hooklets, it has intestine, it has head, and it becomes cyst form. Next. Somiasis again. Schistosomiasis helminthiis that cause neuroschistosomiasis. It is usually the Japonican form. But again, the hematobium and Mansonoid can cause brain infection and specific brain lesion. You see the ova, you see the granuloma. Next. Hydatid cyst. But this, see how it looks? Very characteristic. And I actually المفروض to diagnose hydatid cyst. You see a radio lucent. Perfect cyst. Yeah. Perfect cyst. This is hydatid cyst. Again, hydatid cyst is a cystoid, the tapeworm. It can involve the brain. Historically, usually that one you'll see historically. Next, you'll see the morphology. You'll see the scoliosis. شايفينهم there. وتحت لهم الجرانيولار layer وبعدين اللامينيتد layer. Laminated layer. Yeah, beautiful. You know, it's very easy to diagnose in histology. Next, sarcoidosis. Now, we have to talk about infections, but there are infections characterized by granuloma formation. And these granulomas of the brain is similar to brain tumors in many aspects, presentation and radiological finding. That's why they are subjected to biopsies. يعني ممكن يخشوا يفتحوا المخدر على سنهم to diagnose the brain tumor. We go granuloma. Because of granulomas كثيرة. Sarcoidosis, tuberculosis, الفنجاي, الشيستوسوما, الأكانثوأميبا, not the amoeba histolytica. Acanthoamoeba is a different type of amoeba. Can cause brain granulomas. الأهم فيهم واحد by the way في التروبيك التروبيكولوزيس عندنا نحن افريقيا. في الويست في نورث يوروب بالذات في السويد والدنمارك sarcoidosis. Sarcoidosis is very common disease. Sarcoidosis is mainly a respiratory disease, a pulmonary disease. However, it is a multi-system disease. It involves almost every organ. Like in the presentation, usually it's like respiratory symptoms and uveitis or iritis or that. The eye, the skin, and the lung. These are the main. Like in some of them, they involve the brain and they come with specific lesion, sarcoidosis. Okay? And then you have the tuberculosis, and you have all the historical features of this granulomas infection. Next. Next. ما في حاجة. طيب دي نحن كل اللفة دي عشان نجيكم للحتة دي. دي أهم. This is the most important. Because a brain biopsy is most probably. A specific brain lesion is most probably a tumor. وبعدين, if you want to know the classification of tumors, you just look at the normal structure of an organ. From it, you can know what type of tumors you can get. So, what do you have in the brain? In the brain, you have the meninges, right? These meninges are lined by meningeal. These meningeal cells can abnormally proliferate and cause a tumor. And they call it tumor. Okay? You come down to the cortical areas. The cortical areas are predominantly neurons. So a tumor from that area is called a neuroma. But usually it is not a pure tumor. Usually it is combined with glial proliferation. So we get neurogliomas. Okay? And in the white substances, you get the astrocytes and the oligocells. So the oligocells produce the myelin, while the astrocyte produce the fibrillary structure of the brain. And these, both of them, they ensheath the axons or the nerve fibers. So if you get a tumor from the astrocyte, you call it astrocyte. If you get a tumor from the oligocyte, you call it oligodendroglioma. There is another type of cells that line the ventricular system. It is a columnar cells called ependymal cells. So if you have a tumor arising in these cells, you call it ependymal. طيب. بعدين عندنا these are the primary tumors. عندنا كمان metastatic tumors هنتكلم عنهم. وعندنا tumors associated with familial syndromes. لازم تعرفهم يعني معرفة عامة. وعندنا a group of tumor which is primitive. When you look at it, you will not know from where it is coming. It is primitive cell. And usually these primitive tumor, they call it small blue cell. You know, all the primitive cells in the body are small and blue. When they differentiate, then they acquire more like blood, they acquire the features of functionality. إذا كرياتين producing تلقى فيها كرياتين إذا ما بعرف كده. لكن usually, so the smallest cell in the body that from which a ganglion cell is derived is called a neuroblast. The neuroblasts are small blue cells unlikely to be the cause of most primitive tumors in the brain. Okay, next. طيب البرين تيومر زي بيختلفوا عن باقي التيومرز في الجسم. اختلاف كبير جدا جدا. أول حاجة they don't have a pre-malignant condition. وش لأنه ما عندهم؟ to study that. يعني ممكن تتباشر brain to see that. لكن for example you can do cervical smears, you can do cervical biopsy to study pre-malignant lesion في cervix. You can do skin biopsies to study pre-malignant diseases of the skin. You can do colonoscopy and gastroscopy to study pre-malignant diseases of the vulva. Like you cannot study the pre-malignant or the pre-tumoral lesions of the brain. It is not subjected to study. They might be there, but you don't know them. So you are not aware of insight or pre-malignant. This is number one. Number two, ما في classification benign malignant. ما في. You grade them. لكن كلهم they behave terribly bad. يعني ما زي باقي الأورجانز نقول مثلا فايبر أدينوما كارسينوما لا. An astrocytoma can behave nicely or aggressively. It is the same astrocytoma, but it varies in the grade. Okay, so the behavior is not a malignant benign behavior. It is the grade of the tumor. لا ليه؟ لأنه قاعدين في حتة limited. حتى البيتويتري ادينوما اللي اسمها ادينوما it can behave notoriously bad. It can produce increased intracranial pressure. صح؟ It can present as small as so that is it. So or it can produce a hormone like something like that. Okay. And secondly, anatomic size is very important. يعني الكولونيك كارسينوما اذا كانت في السيكا مره في بتاع كله زي بعض، لكن في البرين لا. where the tumor is situated is very important. Very important. الحاجه الثانيه انه they don't spread outside the brain unless you have a shunt. This is the only way brain tumors goes outside the skull and involve other organs. If you have a shunt, tumor cells go to the shunt in the blood, settle somewhere and grow. But هاي كعبة ما في حاجة كويسة brain tumors. يا أبوي هي عنده brain tumor. قلنا كويس. نعالجه ولا نعالج السكندريز؟ يكون عنده brain tumor وسكندريز. شوف كانسر ده كانسر أهم حاجة فيه الستيج. What is the stage of cancer? It is the size and locality of the tumor. Stage 1, tumor confined to the organ. Stage 2, local invasive tumor. Stage 3, tumor going to the lymph node. Stage 4, tumor traveling distantly. Which is good for the patient to be clinician. Stage 4 or stage 1? So if you have metastasis of brain tumor, this is not, it's nothing good. والحاجة المهمة جدا جدا لازم تعرفوها ثاني يا شباب أنه البرين tumors are not classified morphologically. يعني نحن الحين we classify most of the tumor by morphological features. البرين tumor لا. Their classification involves molecular and genetics. كله لازم you have to do. أي لاب ما بيعمل genetics the brain tumors will not be able to classify them accurately. there is a high risk of mixing them. اوكي؟ هسه عرفتوا البرين تيومرز تسميتهم تعتمد على السيل اوف اوريجين. مننجيال بندايمال استروسايت اوليجو كده كويس. بعدين الحاجه الثانيه انه they don't have inside too. Okay, and classifications very importantly involve genetics and molecular. Okay. يا هنتكلم عن الجريد. هنتكلم عن الجريد مهمة جدا. الجريد مهمة جدا. الجريد لأنه زي ما قلت لكم ما في بناين مالجنان. في جريد 1 2 3 4 هنتكلم عنهم بالتفصيل. كل ما مشيت ل 4 كده كل ما كان البروجنوز سيء. كويس؟ طيب البرين تيومرز you see there 24 per 100,000 ما شوية دوي يعني معناته 0.24%. It's not little. But you know it involves adults more than children. وفي adults it involves the supratentorial region أكثر. في children عشان كده لما تجينا من السيرجن أهم حاجة يقول لك supratentorial ولا infratentorial. لأنه السوبرتنتوريال تيومر ديل جروب والانفراتنتوريال تيومر ديل جروب. كويس؟ يلا to go to the next. طيب نحن قلنا النيم it depends على السيل اوف اوريجين، لكن في الجلايوماز ديل بيطلعوا من two cells الاستروسايت والاوليجو. كويس؟ sometimes you will be able to tell والله this is an astrocytoma. sometimes تقول والله this is oligoglioma. But other times you cannot classify them into oligo or astrocytoma. The higher grade it is, the difficult to separate oligo from astrocytoma. عشان كده بنستعمل الترمينولوجي جلايوما. وبعض مرات كثير جدا انا بشخص هاي جريد ولو جريد ما بكون عارف ذلك. كويس؟ لكن الجلايوماز ديل والبرين تيومرز كلهم they are graded into 4 grades excluding meningeal tumors. Meningeal tumors are graded into 3 grades. لكن كل other brain tumors once you diagnose them you have to tell the clinician what WHO grade they are. كويس؟ كلهم they are graded from 1 to 4. في الجلايوما ما في حاجة اسمها جريد 1 جلايوما. لأنه جريد 1 جلايوما دي ما بتفرق من الجلايوزيس. It's very similar to gliosis. With cellularity wise, structurally. So people usually they avoid. أنا زمان لما كنت resident جزء عملت روتيشن في النيوروباثولوجي كنا بنقول أستروسايتوما جريد 1 to 2. أستروسايتوما جريد 3 to 4. لكن حسي ما بتشوف جريد 1. كويس؟ في تيومر by definition they are 2 to 3 وفي تيومر by definition they are 4. الجريدنج ده بيعتمد على شنو؟ بيعتمد على الحاجات المكتوبة تحدي. How serious the tumor is, how the nuclei look like, are they polymorphic or uniform, how often you see mitosis, and whether you have vascular proliferation and necrosis. الفاسكولار proliferation and necrosis دول مهمين جدا جدا جدا. دول طوالي بيفرقوا لك بين 3 و 4. أي حاجة فيها vascular proliferation and necrosis دي جريد 4 على طول. إذا كان عندك ميتوز وبليومورفيزم بدون vascular proliferation and necrosis this is grade 3. ما عندك vascular proliferation ولا mitosis ولا necrosis and it is mainly increased cellularity, this is grade 1, grade 1 to 2 or 2. اوكي؟ يعني الفاسكولار proliferation والنيكروز ديل بيقسموهم لك لاثنين.
3 و4.
3 و4؟ لا 4.
4 بس؟
اي vascular proliferation والنيكروز 4 على طول. polymorphism mitosis 3. لا ده 2. next طيب زي ما قلت لكم انه البرين تيومر ديل بالذات الجلايومز اهم حاجه فيهم الموليكولار كلاسيفيكيشن. كويس؟ ففي تو ثينجز كثيره، لكن بالنسبه لكم انتم في المستوى ده حتى لو بقيتوا جنرال فيزيشنز او حتى بقيتوا نيروسيرجنز عايزين تعرفوا تفرقوا بين الاستروسايتوما والجليوبلاستوما والإليوجودندروجلايوما والبلوستيكس استروسايتوما. كويس؟ لو لاحظتوا بعضهم أوليجو وبعضهم أسترو وفي النص نمرة 2 دي جلايوبلاستوما معروفة يعني ما يقدر تقول دي شنو. طيب في حاجة اسمها الايسوسيتريت دي هيدروجينيز. It is an enzyme involved in electron transport. Krebs cycle. كويس؟ Some of these glial tumors are associated with mutation in IDH. كويس؟ اللي هم شنو؟ الأستروسايتوما is always IDH mutated. So if you have a glioma, okay, and it is IDH mutated, it is not a glioblastoma. لأنه الجليوبلاستوما is IDH wild. تعرفوا الفرق بين وايد وميوتيتد شنو؟ لا. الوايد جين is a normal gene. يسموه وايد سبحان الله. الجين which is abnormal has an abnormal sequence. في واحد من النيوكليوتايد قاعد غلط وبالتالي في امينو اسيد هناك في البروتين البروس قاعد غلط بيسموها ميوتيتد. فالاستروسايتوماز والاوليغودندروجلايوماز are both mutated. إذا الجلايوما mutated تسميها جلايوبلاستوما. كويس؟ هنعرف إنه كل واحد فيهم يعتبر. طيب كيف تفرق بين الاستروسايتوما والاوليغودندروجلايوما؟ الاثنين IDH mutated. الفرق بيناتهم أنه deletions, yes. You know, oligodendroglioma has this chromosome 1 long arm or chromosome 19 short arm deletions. ما فيهم. تعمل cytogenetics يقول لك والله في I 1B والله 19 Q deletion. This is طوال تفرق لك بين شنو؟ الاوليgodendroglioma والاستروسايتوما. البلوسيتيك استروسايتوما this is a special category of astrocytomas. It has nothing to do with IDH. It is a wild IDH. Lakin it affects certain age group and it occurs in a certain areas of the brain and they are always great. Always. كويس؟ طيب خلينا نجي نبدأ this into grades. نشوفهم بنسميهم شنو value grade then. Next. Astrocytoma. كويس؟ When you call a tumor astrocytoma IDH mutant, خلاص, this is fall always within the grade 2 to 3. كويس؟ they present with seizure, headache, localized, وبعدين they occur in the old and they all most of the time they are supratentorial. كويس؟ إذا كانت فيها pleomorphism وميتوزيس it is 3. إذا ما فيها pleomorphism وميتوزيس grade شنو؟ 2. كويس؟ وما فيهم دائما بيكونوا نكروز ولا هيموريج. كويس؟ وهم they are derived from astrocyte. That's why the name is astrocytoma and these are fibrillary glial cells. They produce the fibrillary cells of the brain. Okay? Next. زي ما قلت لكم الجريدنج ده بيجي بعد ما تتأكد انها astrocytoma. إذا كانت ما فيها الحاجات دي 2. إذا فيها البليومورفيزم والميتوزيس 3. لكن إذا فيها vascular proliferation شايفينه؟ فوق لا فوق زي الجلوميريولوس فوق ده أيوه يا the endothelial cells proliferate and give the vessels a glomerulus shape. شفت الجلوميرولايتو؟ This is, once you see the vascular proliferation, this is grade 4. So astrocytoma is diagnosed by IDH mutation and graded based on the polymorphism, mitosis, and vascular proliferation. You don't see a diagnosis of astrocytoma grade 1. ما في. astrocytoma grade 1 ده ممكن يكون gliosis عادي. Okay. Next. And glioblastoma, it is wild, and it is always grade 4. Always. أول ما تشوف كلمة glioblastoma في الريبورت, this is the highest grade. It is grade 4. Okay. It is very aggressive tumor.
The age حقه؟
6 to 8 decades مش years. 60 ل 80 سنة.
60 ل 80 سنة قلت العمر حقها طويل يعني.
من 60 ل 80 سنة بتحصل عادي. Usually after the 80, you know, in many places, even the colon, everything comes down. Cancer is very حاجة غريبة مش كده؟ After the 80, the cancer incidence becomes down. After the 80. I don't know. لكن glioblastoma فيها حاجتين مهمات جدا. لازم تكون IDH mutant وتكون grade 4. يعني ما ممكن تقول والله دي glioblastoma IDH mutant أو تقول glioblastoma grade C. ما في كده. Once you say glioblastoma, by definition, this is grade 4 and it is wild type. Very poor prognosis. شايفينها هنا. Next. This is a glioblastoma. Look at the cellularity. Very cellular. Look at the vascular proliferation. Look at the necrosis. Far left. Very cellular. Right in the middle. With vascular proliferation. Okay? Once you see a tumor like this is a glioblastoma. It could be astrocytoma grade 4, by the way. If it is what? If it is IDH. Very clear. You are very clear about it. Huh? Fine. Next. I'm not joking, I'm not joking. Okay. يا إمام والله فدار بالمناسبة تعرفين الشعب؟ عندي قوي على الأعراض ولا كده؟ عندي قوي معرفة مش كده؟ تعرفين شديد؟ I'm just joking really. I don't know. Just to break the monotony. Oligodendroglioma are always IDH mutant, where they are always 2 to 3. ما بتشوف فيهم 4. ما زي الأستروسايتوما. You can see astrocytoma grade 4. لكن في الأوليغودندروglioma astrocytoma grade 4 بتشوفي. glioblastoma by definition is grade 4. oligodendrogliomas are grade 2 to 3. كويس؟ بيحصلوا في الثيرد decade of life والفورث decade of life. 5 to 15% من البرين تيومر they are slowly growing and very subtle presentation. كويس؟ أهم حاجة فيهم أنه عندهم مع الميوتيشن في ال IDH عندهم deletion of long arm 1 chromosome or short arm 19 chromosome. Okay? And they have characteristic morphology, by the way. Next. They have what is called chicken wire vascular proliferation. شايفين البسلز هنا بتختلف عن البسلز اللي شفناها في الاسوسايتوما زي الفور والجلايوبلاستوما. They are chicken wire زي الchicken wire زي قفص الجدار النمل بتاع الجدار. This is one thing. The other very characteristic also they have next they have egg fried appearance. شوفي النيوكليوس والسيتوبلازم are almost empty. They are fried egg. So these two appearances plus the IDH plus the cytogenetics will help you to appropriately classify them. لأنك أنت مثلا لو شغال في حتة ما فيها جينيتكس وشفت التو فيتشر زي تتوكل على تقولي oligodendroglioma grade 2 to 3 مش كده؟ Next. ependymoma. The ependymomas there are arising from the ependymal cells that line the ventricular system. They are always 2 to 3. ما يوصلوا فوق أصله. كويس؟ و 15% they have very good prognosis they are histologically characterized by papillary formation and perivascular. وركزوا في perivascular arrangement لأنه في different arrangements. Rosetting around something. These tumors they rosette around brain, they rosette but not around blood vessels. هتشوفوها. Okay. Next. هذه perivascular rosetting. شايفينها؟ Yeah. When the tumor cells form a rosette around a blood vessel. This is very characteristic of ependymoma. Next. ايوه نجي ناو للانفراتنتورال تيومر وده الكون في التشيلدرن واهم حاجه فيهم الميدالوبلاستوما. والميدالوبلاستوما is a primitive tumor always in the cerebellum. والتشايلد اول ما يجيب طايل بالسيربيلر ديزيز اتاكسيا ونستاجموس ودبل فيجن وهاي you have to exclude medulloblastom. كويس؟ It is a blue small cell tumor most likely of neuroplastic origin. ناس ما متأكدين لأنه النيوروبلاستوما is a tumor again definitely of neuro origin. Medulloblastom, some people they think it is neuroblast, others they say no, it is not. Okay, next. This is how they look. شايفين الروزيت هنا is not around blood vessels. It is around neurobial cells, like the tissues. This is يمكن يجيبوا لك في الامتحان ما تفرق بيناتهم لما عرفت الفرق بين perivascular rosetting or very neurobial cells. Okay, but both of them they look similar to small blue cells. Next. Meningioma is a tumor of the meninges. Okay, they arise from the meningeal cervix, the disease of adult. They fall in grades between 1 to 3. One is benign. قلت لكم دي الفرق الوحيد من البنين. One is benign. أهم medulloblastom is always grade 4. ولا بتحتاج تكتبها ذاتك. لما تكون medulloblastom, this tumor behave like grade 4. Okay, meningioma is a meningocele tumor. It occurs mainly in adults. It could be benign or atypical or high grade. كويس depending on the cellularity, mitosis, pleomorphism, necrosis, and brain invasion. A tumor أول ما to invade the brain, it is not benign. It is either atypical or high grade. Okay, very important. Tumor brain invasion. Next.
High grade يعني
malignant.
ذاته؟
ها؟
النمبر ذاته يعني ليه الهاي جريد فرق شو من الجريد 1؟
لا بس هم ذاك because you know you have هناك عندك المشرف في جريد 1 عشان كده they go 1 2 3 4 وذي ignore جريد 1 لانه يشبه الجلايوزيس. ونحن انا بتذكر زمان كنا دائما بنكتب بعض مرات انا كنت ريزيدنت في نيوروباثولوجي نكتب جلايوزيس فيروس اسوسايتوما جريد 1 ده زمان نكتبهم دائما مع بعض يعني ما قدرنا نفرق بيناتهم. اوكي لكن هنا المننجيوما grade 1 is there. It's called a benign tumor. Meningioma is a benign tumor. When it starts behave strangely and it looks strangely, عندها mitosis, pleomorphism بيسميها atypical meningioma, or it invades the brain substance. And then the malignant meningioma is overtly malignant. يعني عندها كل الفيشر يشوفوا نعم. Meningiomas are of different types. Some of them are called meningocele. They have this herb structure. Some of them are called fibroblastic. They look like a fibrous tissue. Next. Some of them they have Samama bodies. Samama bodies are calcification. A lot of them they look transitional. The هم fibrous ولا هم meningocele. They call them transitional. Next. And some of them they could be secretory when they have secretions, and the grade depends on the cellularity, presence of mitosis, polymorphism, necrosis, and involvement of the brain. Okay? So the malignant one, far to the right, is obviously malignant. ما بتحتاج علم كثير. Looks, the tumor cells are big, they have a chromatic, they are polymorphic, they have plentiful mitosis, okay, and there is always necrosis. And then you have tumors in the middle, they call them atypical, and then you have the benign that look innocent. Call them benign.
Will it represent tumors?
Will
it represent tumors?
Tumor cells, the blue there, full of tumor cells. Yeah? Ganglioneuroma. These are tumors of the neurons. They always come together with glial proliferation. That's why they call them ganglioneuroma. تعرف هذول neurons and ganglions are synonyms مش كده؟ عارفين كده ولا لا؟ يعني واحد قال لك ganglion cell ولا نيورون ده بس يعني في ganglion الثانية اللي هي composite structure with many ganglion عندها اتياتيك function. لكن الجانجليون and neurons are synonyms. في التيومرز ما بيستعملوا الناس كلمة أنا جاي ما بيستعملوا كلمة نيوروما في البرين لأن نيوروما is always linked to Schwann cells. Schwann cells في البرين ما في. اوكي فعندنا ganglioneuroma. اوكي next هم always grade 1. Always grade 1. They are slowly growing tumors. Patient present with focal symptoms, seizures, most of the time. Okay. Then you have this tumor, dent is called next. This desmoplastic neuroepithelial tumor. This is a very very rare tumor. اسمها dent. أنا لما كنت resident شفتها 15 كيس ما كنا عارفين وش. تقعد أنا من 14 نقول شنو. لكن لاحظنا حاجة أنها mostly في temporal lobe وmost of the patient comes with seizures. لغاية ما جات واحدة فرنسية في باريس she described it, a big series, and she gave them a name, and people know the prognosis that they are grade 1, and they are temporal, and they present with epilepsy. Once you excite them, they will exude it. يسموهم desmoplastic neuroepithelial tumor. 15 مرة لكن ما عرفتهم والله. تعرفين عرفتهم منين؟ بعد ما تخرجت واشتغلت وجات دولة شغل حتى عرفتها. Fortunately زرت المكان where they describe it in Paris وشفت السيريز كلها. كويس؟ وهم عبارة عن cords of neuron cells look of variable size and shape in columns. This is the main picture with cystic spaces around them. Okay. Next. أيوة قلنا في syndromes associated with brain tumors. Two syndromes. Von Hippel-Lindau syndrome. Okay. Von Hippel-Lindau syndrome is associated with is having to them a tumor called hemangioblastoma. And this tumor can develop in the brain or the cerebellum. كويس؟ لكن انتوا عارفين الفون هيبل-لينداو syndrome ده has got many tumors. Some of them in the kidney, بيسموها angiomyolipoma. You can get some pancreatic tumors. You can get some renal cell carcinomas. It is a syndrome of neoplasia. واحدة من الحتات اللي فيها neoplasia is the brain. بس فيها hemangioblastoma. And this how it looks. The brain بيحصل في السيربيلم. It is a vascular tumor. See these red are RBCs. Between them are vacuolated cells. Like in this tumor, you can see it also in the retina. Okay, this is one of the syndrome. The next syndrome. Next is tuberous sclerosis. Again, this is autosomal dominant syndrome. Whereas for patients, they have mental retardation, they have multiple adenomas in the skin, okay, and they have epilepsy, and they have heterotopias, they سموها هي, and the proper name for it, some even diamond giant cell astrocytes. You said these are astrocytes. You see how big they are? And they form a mass in subendymal gland cell astrocytomas. Other people, they call it heterotopia or hamartoma. Okay? So this again, tumor occurs in the central nervous system, in tuberous sclerosis, a syndrome in which you get many tumors, one of them in the kidney. Next.
What was the other name? The two tiny?
Heterotopia or subendymal hamartoma or subendymal gland cell. Have characteristics. طيب, the presentation of these tumors, you know, it depends on where they are. صحيح ولا كيف? So early, if you have a distortion of meninges and blood vessels, you get headache. If you have compression of optic nerve, you get diabetes. If you have distortion of the medulla, you get rheumatism. Lately, when they start to grow bigger and bigger, if you have compression of the oculomotor nerve, you get papillary constriction and irritation. If you have tractions on or pressure on the abducens nerve, you get abducens palsy. Abducens palsy. Okay, if it compresses the posterior cerebral artery, you get occipital infarction. So, affect the cerebral peduncles, then you get hemiplegia, and so on. If it involves the medulla, you can have high blood pressure, slow heart rate. So, the focal symptoms, it depends very much on the repetitive. I don't care. Any piece of tissue. I just call it what I call it. Okay? Next. Metastatic tumors of the brain. And بعدين ده المهمين. Metastatic tumors, they affect the brain or the cancer in the body. They affect the brain in two ways. Either directly by metastasis. This is the last minute. This is the last minute. Is metastasis, or through a process that involves production of autoantibodies, what is called paraneoplastic syndrome. This is a two-way in which the brain is involved in carcinomas outside the brain. Okay, the metastasis in the brain, most of the time they come from the lung, followed by breast, kidney, colon, and malignant melanoma. The paraneoplastic syndrome, is a syndrome whereby the immune system develops antibodies against a tumor antigen. This antigen will come to the brain and it will destroy it, cause many problems. It can cause cerebellar degeneration and ataxia as a paraneoplastic syndrome. The tumor is not there, it does not reach the brain, but the antibodies of that tumor antigen will damage the brain. Or you can get limbic encephalitis, limbic involvement of the limbic body. It's presented with dementia, or you can get peripheral nerve neuropathy. So, the paraneoplastic syndrome in the CNS is very important, more important than the physical presence of the tumor itself in other brain cells. Okay? Paraneoplastic. You can get ataxia, you can get dementia, and you get sensory, peripheral nerve sensory abnormalities. Okay? It's called paraneoplastic. Paraneoplastic يعني ما neoplastic يعني. أنت رزقكم سؤال خلاص انتهينا. رزقكم sequence of events edema. كل infection, tumors, all of this they produce edema. Edema, it will increase more the pressure. يعني the presence of a tumor cause increase in the temperature. لكن edema add to it. Infections is mainly edema. Infarctions is mainly edema. Okay? You have edema, you have increase in the pressure, you get compression of the brain, you get displacement of the brain. Okay? Once the brain starts to move, you can have herniation within your skull. From supratentorial to infratentorial. Or from right to left. Okay? And then, as the pressure increasing and things progress, you get distortion of the brain stem with all the symptoms of brain stem involvement. Pulse, breathing, all will be affected. مش كده؟ بعدين cornea herniation and death. This is a sequence of events in increased intracranial pressure. Next, this is different herniation. You know, it can move from left to right, or from up through the tentorium into infratentorial region, and ultimately you get herniation, the cerebellum and the medulla oblongata, and this. Next. خلاص؟ تعبتوا؟ فترتوا؟ Did you enjoy it? شكرا لكم. I'm happy to hear that. اديني USB. إذا عايزين المحاضرة دي عندك مسجلة مش كده؟ خلاص اوكي. اقروها كفاية. ما تقدر لي هي ربع فضل أنا